Bismillah ar-Rahman ar-Rahim. It's a great pleasure for me to chair this session with Professor Peter Severovich. The session will be on heart failure guidelines in clinical practice. And our first speaker is Professor Walid Pasata. He will talk about iron deficiency in heart failure, where we are. The floor is yours.
Thank you very much for the invitation, and I'm very happy to be here. I'm Syrian, but I'm living in the United States, so we move from one place to another. I mean, first time I came to Cairo, 1974, so almost 50 years ago. So I'm moving and moving. I'll be talking about iron deficiency in heart failure. Where are we? I mean, this is very important. And declaration of interest, there is no problem because I'm moving with many of the pharmaceutical companies. I mean, when we are talking about people who are living and who are dying, I mean, the most and the worst one is heart failure. And you see here that heart failure and heart disease is most problem compared to diabetes, compared to stroke, compared to COVID. So we have to speak and to treat patients who are having problem. I mean, once you have anemia and the iron is low, you will see that the all-cause mortality is more if you have the serum iron is low. So I mean, you have to improve the serum iron and to make sure that it is better. And the other problem really, if you have anemia is common in heart failure and it is associated, I mean, anemia is present, it means that the survival is less. So heart failure and anemia is worse and worse, and we have to make sure that we have to treat heart failure and we have to treat anemia. I mean, this is very important. And the other point really is showing association between iron deficiency and mortality in heart failure. I mean, you will see here that mortality increase when ID is present. I mean, when iron deficiency is present, it means that survival is less than that. So it's not only anemia, it is iron deficiency. We have to make sure that we have to check iron deficiency and we have to check anemia, both of them in patients with heart failure. I mean, this is very important. And you will see here that prevalence of iron deficiency in heart failure, it is almost 50% of the people. So it's not only anemia, iron deficiency. So we have to check the iron, how much in patients who are having heart failure. So this is very important to improve the things. And you'll see here clearly that if there is no anemia, okay, it's slightly reasonable. And if there is anemia, it is much worse compared to, I mean, you have to check TSAT and serum iron and all of these. So I mean, we have to check many things for the patients to make sure who are they. Patients with heart failure are regularly screened. I mean, what we have to check: anemia, iron deficiency with full blood count, serum ferritin, and TSAT. I mean, this is very important for that. And iron deficiency can present independently of anemia. So, I mean, you don't have anemia probably, but you have iron deficiency. And it is more clear if you have chronic heart failure, it is 55%. If you have acute heart failure, it is more than 80%. So, I mean, iron deficiency is very bad, really. And how we'll check the anemia for patients? I mean, for women, for women, if it is below 12, I mean, this is bad. For men, if it is below 13, it is bad. And iron deficiency and anemia are common in heart failure. And reduced exercise capacity, recurrent heart failure, hospitalization, so you'll have another problem if you have anemia and iron deficiency, and high cardiovascular and all-cause mortality. So now we have clear that if we have heart failure anemia, iron deficiency, all of these, will create problem, and we have to check that one very clearly. And will show clearly really that you will see here that worsening heart failure event or primary composite or whatever, all of these, or all-cause mortality. I mean, if you have iron deficiency, it is more and more for these problems. So, I mean, we don't need only to check anemia, we have to check iron deficiency for the patients. I mean, I am also created and founder of the Saudi Hypertension Management Society 25 years ago. And today we started another one for hypertension in Syria. Today we started, and I am the board for that one. And you see all of these people. And also in the European Society of Cardiology, always I'll be in charge for hypertension and giving presentation and all of these. So this is very important. The other point, the prevalence of anemia, the prevalence of anemia and the severity, I mean, you will see here that if you have heart failure very bad, it will show you clearly that you will have more problems of what? Decrease in the hemoglobin of that one, and will create some more problems. And again, it will show prevalence of iron deficiency. You will see that if you have NIHA 4, it is more than NIHA 1, more than NIHA 2. And if you have heart failure, reduced ejection fraction, it is slightly reasonable. If preserved ejection fraction, it's more worse and worse. So you have to check your patients, the quality of their heart failure, to make sure exactly what they have. When we are talking about that one, we'll see that iron deficiency, what did the guideline will say? I mean, we have created the guidelines from the European Society, and I am presenter for that one in the European Society of Cardiology. And you see here Dr. Majdi, he was over there, and myself also regarding the European Society of Cardiology heart failure. And will tell you that we are in charge of many presentations for heart failure, because heart failure is very bad regarding more than acute myocardial infarction and whatever. You will see here, if you have recommended diagnosis test in patients with chronic heart failure, you have to check iron status, TSAT, and ferritin. So it's not only you have to check anemia, you have to check many things for that one. And at the same time, you will see here that iron deficiency with full blood count and serum ferritin and TSAT, I mean, all of these should be checked for those patients, and this is very important. And sometimes you have to check if serum ferritin is 100 to almost 300 with TSAT below 20%. This will create more problems, and you have to know that one. Ferric carboxy maltose should be considered for iron deficiency. So, I mean, this is one of the problems for iron deficiency in heart failure, and this is important. I mean, this is the European Society of Cardiology, the new guideline, which was recently. Intravenous iron supplement is recommended in symptomatic patients with heart failure, reduced ejection fraction, and mid-range ejection fraction. So, I mean, and this will improve quality of life. So we have to improve the iron deficiency, and especially in patients who are having heart failure, and this will improve things. And this is the American College of Cardiology in patients with heart failure, reduced ejection fraction, and iron deficiency with and without anemia. Intravenous iron replacement is responsible to improve quality of life. So, I mean, this is always we are talking about European Society of Cardiology, American guidelines, and all of these will show something. And this is one of the studies. It is showing clearly that if the patient is having ferric derisomaltose, and it is very clear that primary cardiovascular mortality, it is more than others, and hospitalization is more, and all of these will create problems. And it is showing that IV ferric somaltose administration was associated with lower risk of hospitalization and with heart failure. So I mean, this is very important that this will improve things for the patients. And the other point really, that if you have a patient who are having and using ferric carboxymaltose, it will show very clearly that things are better than placebo if the patient is having total heart failure, hospitalization, and cardiovascular death. So it is better with ferric carboxymaltose. And heart failure, hospitalization, and death, it is better. Total heart failure, hospitalization, it is better. So always it is showing that it's very important for that one. Iron deficiency, treated with IV ferric carboxymaltose, totally evidence and going into the same direction. So I mean, it should be given IV, it's not oral. We need to pay more attention to the presence of iron deficiency in spite of normal hemoglobin. I mean, this is very important. We have to check the patient with hypertension and the type of iron deficiency and what we have to do for that one. And ferric carboxymaltose for iron deficiency at discharge after acute myocardial infarction, it will show very clearly really that intravenous iron supplementation do not reduce mortality in heart failure patients and decrease heart failure hospitalization. So I mean, this is important, and it will show clearly that IV iron supplementation is recommended in patients with heart failure reduced ejection fraction. What it will improve? It will improve improve symptoms, quality of life, reduce risk of heart failure hospitalization, and exercise capacity. So all of these will be much better for the patients. And the last point really, that if you have a patient with heart failure and the patient is taking dapagliflozin, does it help you for that patient? Dapagliflozin appeared to increase iron. So this is important to give SGLT2 for patients who are having reduced iron for that patient with heart failure. And this will show you very clearly that no iron deficient, okay, it will show that there is no much improvement, but if there is iron deficient and the patient is getting dapagliflozin, it will show better and better compared to placebo. So it is very nice and very useful. The last presentation, intravenous iron infusion in heart failure patients. Oral iron is ineffective, so don't give oral iron. But IV iron infusion in heart failure reduces composite risk for hospitalization and for mortality. Thank you very much, and I'll be moving back to the United States of America because I have many things over there. I'll be there, and thank you very much. I'm very happy to see you.
Thank you very much, Dr. Satta. You underline an important fact that treating heart failure is also depending on how we treat comorbidities. Heart Failure Association of the ESC underwent the registry, so-called Heart Failure Observe, in whom we were trying to see how much this kind of analysis is done in the tertiary institution all over the Europe. And the results are not only disappointing, but also alarming, which means that less than 12% of the patient are having checked her intravenous iron. So that means that we are preaching, but we are not achieving too much. Yeah. So could you tell us, so you live in United States or in, I did not understand where you live, because I would like to ask you, what's the situation with the iron supplementation in your country, whatever that country can be?
Yeah. I mean, when you have heart failure, we know that there is a problem with the iron deficiency. I mean, we don't check only anemia, we'll check iron deficiency, and it is almost 50% of the patients who are having heart failure. And these patients, they have to improve and to be treated. So, I mean, this is very important. And actually, I'm looking in different places, they don't check and manage how much the patient is having iron or no iron. They will check only anemia sometimes. This is not enough.
That's valid. That's exactly what I want to say. The
Yes.
goal of the meeting like this one is on the first place educational. So we need to exchange our opinions and force the younger physician, but also everybody else, to check for the iron deficiency. Because 12% at the European ground, including the big countries of the West, is not too much.
Yes, I think you are right. And always, I mean, to be honest, really, I mean, in Egypt is different from London, is different from United States. And if you will check for the guidelines, you will see the hypertension in United States. They will tell you if your blood pressure is 130 or more, 80 or more, you have hypertension. In Europe, they will say 140 or more, 90 or more. So, I mean, always we have to do research and we have to do guidelines in different places to make sure exactly how we will improve our patients, really, not only checking for one guideline in the world.
But I may say, on the first place, we need to work on the implementation of the guidelines. Thank you very much.
Thank you very much
Thank you
indeed.
very much.
Thank
The
you.
pleasure was to hear your lecture. And now we have a particular pleasure to hear Professor Mohammed Hassan, who is going to address also one of the important, but also to some extent controversial question, and this is hyperkalemia in heart failure. Is it still a challenge? We may answer, yes, it is. But let's see, please, Mohammed.
Thank you, Professor Peter, for this introduction. In my talk, I will highlight the challenge. Definitely, it's a challenge of hyperkalemia in our patients with heart failure. At the beginning, hyperkalemia is defined as serum potassium more than 5 milliequivalent per liter, and then it's further classified into either mild, if it's between 5 and 5.5, moderate between 5.5 and 6, and then severe if it's more than 6. Hyperkalemia is common in our patients with heart failure. In acute patients, in data actually from PROTECT study about acute heart failure, the incidence of hyperkalemia is around 9%. And those patients is associated with poor prognosis. The mortality is significantly higher in heart failure patients with hyperkalemia compared to those with normal serum potassium. In chronic heart failure patients, due to the use of RAS blockade, MRAs, and the ARNI, actually the incidence may be higher. In the paradigm heart failure trial, for example, the incidence of hyperkalemia, serum potassium more than 5.5 millimole per liter, was between 16 and 17%. So it's really a common problem in our patients with heart failure. And hyperkalemia increases as renal function decline. And we know that renal function in a cardiorenal patients, the incidence of hyperkalemia will be higher, so it may reach up to 25 to 30% when renal function deteriorates, especially with the use of guideline-directed medical treatment with RAS blockade and MRAs. So what are the common etiologies of hyperkalemia in our heart failure patients? Firstly, it could be increased potassium supplementation in diet, metabolic shifts with hyperglycemia and metabolic acidosis, iatrogenic, this is really very important with RAS blockade, MRAs, ARNI. Digoxin and beta blockers sometimes increase the risk of hyperkalemia, chronic kidney disease, and renal tubular acidosis. But importantly, please make sure that the serum potassium is truly high. It's not falsely high, because sometimes it's falsely high, and this may affect your decision, and you deprive your patients from the benefit of guideline-directed therapy. You may discontinue the treatment or even do dose modification, and actually the serum potassium is falsely high. Sometimes it could be falsely high due to mechanical factors just tourniquet, delayed processing of the samples, hemolyzed samples, or exposure of the blood sample to low temperature, 2 or 8, all this cause hemolysis and the release of potassium from the RBCs and give falsely high serum potassium level. Also, some patient factors, even some fear and crying during samples with associated hyperventilation, thrombocytosis also can cause high serum potassium. So double checking this serum potassium in a known patient with normal serum potassium before is important before taking action and depriving the patient from the benefit of our guideline-directed medical treatment. In clinical practice, actually, this is data from the European Society of Cardiology Heart Failure Registry, showed that there is a significant proportion of our patients not taking either ECI or ARPs or MRAs due to hyperkalemia. For example, around 7% of the patients not taking MRAs because of hyperkalemia, and 3% of patients are not taking RAS blockade because of hyperkalemia. This is despite the fact that hyperkalemia does not eliminate the benefit of the guideline-directed medical therapy. If we look at this curve, we'll find that even when the serum potassium between 5 and 6, MRA spironolactone is associated with significantly lower mortality and outcome compared to patients who are taking placebo. So even if the serum potassium between 5 and 6, those patients got benefit from guideline-directed medical treatment. So what to do with these patients? So you start with cautious, either RAS blockade or MRAs, very important close follow-up. So if you initiated ECI or ARP, so you follow your patient every 1 to 2 weeks, and if the serum potassium is persistently above 5.5, so you may decrease the dose, or if it's a small dose, you may discontinue and then follow the patients, and then you may reintroduce again once you find serum potassium. Don't lose hope, because these patients will benefit from this treatment. Regarding MRA, you start also even if the serum potassium more than 5 with close follow-up. If you find the serum potassium more than 6, you will stop the treatment, and then you will see try to modify and treat any other causes that cause hyperkalemia, and then you may reintroduce later on. If the serum potassium between 5.5 and 5.9, so you can do dose modification. If the dose is 50, decrease it to 25. Even if it's 25, give it even every other day. And if it's actually is taking small dose, so you may stop it for a while and then recheck later on. There is many actually drugs that can treat hyperkalemia, the mechanism either by shifting the serum potassium to inside the cell, like insulin beta agonist by stimulating the sodium potassium ATPase, or sodium bicarb actually shifting it through mechanism through its action on the sodium bicarb ATPase, so you can shift the potassium to the intracellular and this will reduce serum potassium. On the other hand, you can also increase the excretion of potassium either in urine or stool. Actually, 90 to 95% of the potassium is excreted in urine, and only 5 to 10% is excreted in feces. So we can increase its urinary excretion by the use of loop diuretics. However, now we have the potassium binders that can increase the fecal excretion of serum potassium and significantly and gives you the chance to introduce the guideline-directed medical treatment. But importantly, look at the diet. Very important. If you have your patients with chronic kidney disease or hyperkalemia, instruct your patient that there is a certain fruits and vegetables actually, and some meals associated with high potassium. For example, vegetables, tomato, avocado actually is very, very rich in potassium, cooked spinach, also in fruits, bananas, cantaloupe, orange juice. So this diet actually could be high. Also the potassium supplementation, also the salt substitutes that contain potassium, you should check all this to avoid this risk in your patient. So just to revise again, if the serum potassium definitely increased more than 6, so you should stop definitely potassium sparing medications. You can give insulin beta agonist to decrease the serum potassium, and also you can use potassium binders. If the potassium between 5 and 6, so at this point you can modify the dose, and then you follow up your patient. If the serum potassium persistently high, more than 5.5, so you can use potassium binders and then follow up your patient. If it's persistently, again, more than 5.5, so you do dose modification, or you may discontinue the RAS blockade or MRAs for a while and then follow up the patients. Now we have actually an opportunity to use a potassium binders which significantly decrease the serum potassium and give you a chance to keep your guideline directed therapy, or not to decrease the dose of RAS blockade, ARNI or MRAs. You know that the first FDA approved potassium binders was SPS. However, it received a warning in 2009 because of doing colonic necrosis and bleeding, and also it's only suitable for patients with acute heart failure, so it's no longer used. Now we have two available potassium binders. We have the Pathomer and the SZC, sodium zirconium cyclosilicate. We have under the name of Lokelma, and actually it's present here in Egypt. Both of them are selective. Actually, SZC is highly selective, and it acts very rapidly. Actually, it works within 1 to 6 hours and significantly decrease the serum potassium. But the sodium zirconium cyclosilicate, under the name of Lokelma, it contains sodium, so you can expect some edema and some salt and water retention in your patient, in addition to having some hypokalemia or disturbance of the electrolytes. Also, Pathomer can lead to hypomagnesemia, hypokalemia, and GIT manifestations. Importantly, both of them has important drug interactions, so they should be given either 2 hours before or 2 hours after the medications, because actually it may interact with the absorption of other medications for your patient. This is the data from the OPAL-HK trial about Pathomer. Showed it lead to significant decrease in the potassium. Also, the rate of discontinuation of the RAS blockade therapy is significantly lower with the patient receive potassium binder compared to placebo, and it's quite safe. The rate of adverse events was quite similar between both groups. However, there is higher risk of having some GIT manifestations, nausea, diarrhea, sometimes constipation, and importantly, the drug interaction with other medications. The same with sodium zirconium cyclosilicate. It works actually more rapidly. If you look at here, the action is very rapid. Within 1 hour, the serum potassium starts to decline. You can reach normal potassium within 24 to 48 hours, and it's dose dependent. So it's with the 10 gram, the degree of reduction of potassium more than 5, and also with the 15 grams. So there is a dose dependent reduction in the serum potassium, and also it acts very rapidly. So it's very effective in patients with, in acute patients with significantly high serum potassium. So my take-home message is that definitely hyperkalemia is challenging. It's common in our patients with heart failure. They have poor prognosis. These patients have significantly higher mortality compared to patients with normal potassium. Make sure that serum potassium is not falsely high, because this will affect your decision. Hyperkalemia does not eliminate the survival benefit of our treatment. So try most of the time to reintroduce the therapy with close follow-up of serum potassium, and definitely if the serum potassium exceeded 5.5 or 6, you will discontinue because of the risk of tachy and bradyarrhythmias and mortality also. So you should closely monitor your patients. Potassium binders now are effective in reducing hyperkalemia. However, we know that they have some side effects. There is a risk of hypokalemia. Pathomer can increase the risk of hypomagnesemia. SZC is associated with increased edema. And now we have some answered questions whether the use of these potassium binders will improve the outcome through enabling to uptitrate and to use optimal therapy of our guideline-directed therapy, and whether these potassium binders can allow a new indication, such the use of MRAs in patients with GFR, for example, less than 30. This actually, and those patients are contraindicated actually to use MRA, so this still need further research. Thank you.
Thank you very much. It was an excellent overview in this complex and to some extent controversial issue. This paper is now open to discussion.
Thanks, Professor Mohammed. What do you think about the continuation of this potassium binder? What's your recommend? Is it to continue as we continue our guideline-mediated therapy, or we can check every 3 months or something like this?
You know, firstly, it's very expensive here in our country. Definitely in acute patients, if you have patients with hyperkalemia, significantly high potassium, so you can use it in the while in hospital in the acute setting, and then you use it in a small dose as a maintenance dose, especially if the patient has long history of hyperkalemia. Then you may, if the serum potassium became normal, so you can, and even especially if there is reversible cause, the kidney function improved, the patient started to adjust his diet, and then you can stop at a time, check closely the serum potassium, and then adjust the doses of RAS blockade, ARNI, or MRAs.
Please, Karen, we have here Karen Sleva, who is the top European and world cardiologist, also the past president of the World Heart Federation. Please.
It's just a brief comment. I really like your lecture.
Thank you.
And I'm really glad you mentioned also the non-medical options to reduce hyperkalemia, and especially the diet. I think that's usually not done. And I have a heart failure clinic every week, and really most of the patients, just by reducing certain types of food, which is high potassium, and simple thing like banana, just telling the patient, I must say, you get there with conservative management in most of the patients.
Thank you.
Thank you, Professor Mohammed. I think nowadays SGL2, one of the new emerging treatment in the heart failure. So it's my great pleasure to introduce Professor Atif Al-Bahri. Professor, he will present the clinical inertia in heart failure management and the role of SGL2 in the whole spectrum of the heart failure with reduced ejection fraction.
Thank you very much for the introduction. If you allow to me, please, this presentation, I can't see anything here. أنا عايزها في الشاشة كلها مش عارف.
طب لحظة بص حضرتك، بس ده نيكست وده باك ماشي وده الليزر.
طيب تمام، افتحها لي الشاشة.
ثانية محمد.
It's not appearing, yes. Okay. Dear Chairman, my dear colleagues, good afternoon. My task is for the clinical inertia that we have in everyday practice. For the SGL2 inhibition across the spectrum of ejection fraction. We know that this is my disclosure. We know that SGL2 inhibitors and the cardiovascular benefits are surprising us every time because they are lucky drugs. I think they are very lucky drugs and surprising us. So the mechanism of actions underlying the cardiovascular benefits of SGL2 inhibition are not fully elucidated yet, but we have some data. For the heart, they improve the energy metabolism, improve the cardiac remodeling, decrease ischemia and reperfusion injury, inhibit sodium hydrogen exchange, decreased oxidative stress, and decreased SGL2 activity. For the kidney, they increased the natriuresis, diuresis, decreased blood glucose due to glycosuria, decreased the hyperuricemia, inhibited sodium hydrogen exchange, and improved the energy metabolism. For the vasculature, decreased inflammation, decreased blood pressure, increased provascular progenitor cells, improved vascular function, and for the whole body, the increased weight loss, inhibited sympathetic nervous system, increased erythropoietin, therefore they decreased the severity of heart failure. The SGL2 inhibition in heart failure across the whole left ventricular ejection fraction spectrum, we learned it from the preclinical and the clinical stages that they can prevent heart failure. And recent studies show that we can use it in heart failure treatment, and they are awesome. And for the SGLT2, Zidaba, and the empagliflozin, and the SGLT2, The SOTA inhibitors are approved by the FDA across the continuum of heart failure, and they have the class 1 recommendation according to the latest European Society of Cardiology guidelines across the left ventricular ejection fraction spectrum. If we take first the HFrEF for less than 40%, we'll find that both DABA, heart failure, EMPEROR reduced. They reduce the risk of cardiovascular death or hospitalization for heart failure in patients with HFrEF by 26 to 25 respectively. And for the meta-analysis of the DABA heart failure and EMPEROR reduced trials, we show the meta-analysis composite of first hospitalization for heart failure or cardiovascular death. As we see, the therapy works across the HFrEF spectrum by age, by sex, by EGFR, by the presence of type 2 diabetes, by ethnicity and region. For the HFmERF and HFpEF, they are also here approved from the driver-like primary endpoint definition, the composite of cardiovascular death and worsening of heart failure. They can be used in HFmERF and HFpEF and reduce the risk by 18% and 24% respectively, and 20% relative risk reduction of primary endpoint with consistent reduction in both components. For the consistent reduction in primary endpoint across the left ventricular ejection fraction range, including among left ventricular ejection more than 60%, as we see, we use it for all these ranges. And for the quality of life, they have a very good quality of life, whatever it is the DABA or the EMPEROR. And for the safety, high safe profile, they were safe and well tolerated across the left ventricular ejection fraction spectrum without excess in serious adverse events or key adverse events of interest. And we see here the influence of the left ventricular ejection fraction on the effect of the SGLT2 inhibition on time to cardiovascular death of heart failure. As we see, the magnitude of the effect of empagliflozin on cardiovascular death or heart failure was clinically meaningful, effect driven mostly by reduction in heart failure hospitalization, and similar in patients with left ventricular ejection fraction below 25% to below 65%, attenuated in patients with an ejection fraction more than 65%. And as I told you in the beginning, this is a very lucky and marvelous drugs. So if we compare them to the ARNI, to the ARB, to the MRA, and digitalis, for this, we will find that the SGLT inhibitors, we can use it all over the range of the ejection fraction. So SGLT2 inhibitors among found additional 4 with class 1A recommendation for HFrEF, updated the ECC guidelines, the class 1A recommendation for HFmERF and HFpEF. And here you see this is one of the most important pillars of HFrEF therapy in 2023. And here for the HFmERF and HFpEF, they are a class 1A recommendation. So the rapid sequence of initiation and optimization of the guideline-directed medical therapy boosted to charge from the strong heart failure show absolute risk reduction by 8.1%. The number needed to treat to prevent one death of heart failure hospitalization over 6 months is 12. Reduction of death, heart failure hospitalization with large absolute risk reduction, improved patient-reported health status and NIHA class, improved congestion, no significant differences in serious adverse events compared with usual care. And for the guidelines show an intensive strategy of initiation and rapid up-titration of evidence-based treatment before discharge and during the frequent and careful follow-up visits in the first 6 weeks following heart failure hospitalization is recommended to reduce the risk of heart failure, re-hospitalization or death, class 1B. In the strong heart failure, the use of ACE, ARB, ARNI, beta blockers, and MRA was evaluated in patients with HFrEF, HFmERF, HFpEF, but also was based only on the triple therapy with neurohormonal modulators. This recommendation also includes the SGLT2 inhibitors, empagliflozin and dapagliflozin, based on recent evidence. So we look for the conventional sequence, which take more than 6 months, and this is bad. But if for the rapid sequencing, we find here all the 3 steps achieved within 4 weeks. And we should not have inertia. We have to start very early using the SGLT in the step 1. And for our knowledge now, that all patients with heart failure are at extremely high risk, because even in patients who say a stable heart failure, which is a misnomer, because there is no stability in heart failure, we find that patients with NIHA class and have no symptoms are at extreme risk. Therefore, there is no stability for heart failure, and all the patients are at high risk. Therefore, the SGLT2 inhibitors can be started irrespective of the left ventricular ejection fraction in hospital or in the transitional immediately after recent hospital discharge at the beginning in the ICU and before the discharge to prevent the clinical inertia. Clinical inertia in heart failure could be defined as a failure to modify therapy according to guidelines when clinically indicated. And multiple reasons can lead to therapeutic inertia: patient apparent stability, falsely suggesting no need for further optimization, and poor awareness of recent therapeutic developments, reinforced by the absence of practice models focusing on achieving therapeutic goals. And importantly, the term stable heart failure should be abandoned because it may perpetuate medical inertia, as recently stressed in an expert consensus document that defines heart failure. In the Get With the Guidelines heart failure registry, they found that among almost 50,000 patients hospitalized for HFrEF in the GWTG heart failure registry, only 1 in 5 patients were discharged with prescriptions for SGLT2 inhibitor therapy, and less than 1 in 10 patients were prescribed quadruple medical therapy. This is what we call clinical inertia. SGLT2 inhibitor discharge rates were similarly low in patients with multiple indications for therapy, including type 2 diabetes and chronic kidney disease. And this is a study which shows the inertia of the prescribing for SGLT2 patients at the discharge, and we have to go forward in order to prevent this inertia. My key points: SGLT inhibitor benefits are seen regardless of ejection fraction or other patients subgroups, including according to age, sex, race, diabetes, or chronic kidney disease. SGLT2 inhibitors are effective across the spectrum of the left ventricular ejection fraction, facilitates ease of use, especially for multidisciplinary groups of clinicians that are less familiar with heart failure data. The latest guidelines and the evidence recommended initiation of the guideline-directed medical treatment, including SGLT2 inhibitors before discharging hospitalized patients with ADHF, and SGLT2 inhibitors do not require dose titration as beta blockers, as RNA, as BRACE inhibitors. There is only 1 dose of each of the evidence-based SGLT2 inhibitors, like DABA, 10 milligram once per day, or EMBA, 10 milligram once per day. And thank you very much for your attention.
Thank you very much, Professor Atef. It was an excellent overview of the effect of SGLT2 inhibitors. Clinical inertia is a major clinical problem, appearing in both outpatient setting, ambulatory work, and the hospitals. So could you tell me what is your experience in Egypt? In what setting clinical inertia are appearing more? And just as a comment, one of the most important effects of the SGLT2 inhibitors is very early action of those drugs.
Yes.
So for EMPA 18, for DAPA 28 days. So it's something which allowed them to be involved very early within the treatment of heart failure patients.
Yes. We noticed this inertia, but I don't want to be offensive. This is an offend if I say that, but some centers and some doctors, they are afraid from the side effect of the SGLT2 inhibitors in diabetic patients, for example, ketoacidosis or dehydration or something like that. But as we see here, there is nothing to do. There is no adverse events. And some are hesitated because you don't know what is the SGLT2 inhibitors because in the past we used it for diabetes. And why for heart failure now? This is about the knowledge. So we need education, more education to implement the guidelines, American College of Cardiology or European Society of Cardiology, and they are updating every day. And as I say, they are lucky drugs, they are good drugs. We should initiate it immediately at the hospital, in the ICU, without fear, and we can use it even if the eGFR, and we should measure the eGFR, not the serum creatinine, because our centers depending on the serum creatinine. If they find serum creatinine 1.4, they are horrible. If you make the eGFR, you find it 52. This is nothing. You have to use it until the GFR is below 30 even, because they improve the kidney function.
Thanks, Professor Atif, for this elegant presentation. I think you highlighted importantly the value of implementing the guidelines. I think this is a global problem, not only in Egypt. The proportion of patients who are receiving guideline-directed therapy in heart failure, the proportion of patients who are taking high-intensity statin and coronary artery disease, you need more education. The inertia for up-titration, just seeing the patient's good, and you are just keeping, okay, you are fine, just keep this medications, you are fine, I'm really worried to increase the dose, you got hypotension, you got dizziness. This is sticking to the evidence. The mortality is lower, the heart failure hospitalization is lower, the quality of life is better, so you need training for the physicians and patient education. I think this of great value.
Even in improved heart failure, as is a study, when they stop the medications, the patients are becoming worse. The patient of heart failure is not a stable patient. He will come again to the hospital, he will be hospitalized. We have to preserve the drugs, the 4 pillars, as long as we need. No protocols, this is guidelines. No protocol for any center, any hospital. As we see in the health insurance, for example, in my city, they place a protocol for heart failure patient. If they are improved for the ejection fraction, they reduce a dose of the RNA, for example, or this is wrong. We have to go forward in order to keep the patient for heart failure improved.
Thanks, Dr. Asser, for your excellent presentation. My question to you is about those with acute coronary syndrome admitted to CCU, who either received dilytic or BCI. Most of them have subtle element of LV dysfunction. Do you recommend the SGLT2 prior to discharge in this subset of patient or not?
If they are going to have heart failure, yes.
Yes.
Because you see the range of the ejection fraction below 25 to below 65. So I have to preserve, because we are now surprising that more reports and more studies are gaining now about this concern.
Okay, thank you.
Clinical inertia is a worldwide phenomenon. Do you have something to say from the South Africa about clinical inertia, Karen? Is there anything specific, because you are living in a different probably world? Do you have anything which can be specific to give us the insight?
I don't think it's so much inertia, but remember, most of the patients are seen not by a cardiologist. They're not even seen by a specialist physician.
Yeah.
They're seen by the general practitioner. And I mean, until the knowledge filters down to the medical school, to the general, it's really not easy. I mean, general practitioners also have to know about a lot of other. So I don't think we should be a little bit less arrogant and just feel a little bit for the GPs who have to learn about all those new droplet up titration, and I really think we need a lot of education, but it needs to start at the medical schools. They have all things. That's the problem.
Thank you for your comments. Thanks, Professor At, for this. So for the sake of time, let's move to the next speaker, Professor Dr. Dua Fuad, Professor of Cardiology at Youth University. She will talk about cardiac contractility modulation therapy in patients with heart failure.
Good evening. Thank you, Mr. Chairman. I'm going to talk about the cardiac contractility modulation therapy as a new hope for management of heart failure. Let's start with guideline-directed medical therapy, and as we all use these drugs, we know that achieving target doses of drug therapy in real-world practice remains challenging. So we need more therapists that can promote reverse remodeling in heart failure patients. These therapies are indicated after major trials that introduce novel treatment strategies in reduced ejection fraction patients. And now we all use ARNI, SGLT2 inhibitors. Vericiguat is a drug that is now approved by the FDA. OM is not yet approved. CRT, as we all know, is indicated in patients with left bundle branch block and ejection fraction of less than 35%. And the bar receptor activating therapy and cardiac contractility modulation therapy at last. So the device was FDA approved at 2019 for the following patients: those having moderate to severe heart failure, NIHA class 2 to 4 despite guideline-directed medical therapy, non-responders or non-indicated patients to CRT, ejection fraction of less than 25 to 45%, and sinus rhythm patients. However, at 2021, the FDA approved the usage of the device in AF patients. What is the device? Actually, it's a pulse generator. It's not a pacemaker, where any commercially available leads with active fixation can be used. The leads are fixed in the right ventricular septum, 2 centimeters apart. The battery is rechargeable weekly. So how to deliver the therapy? The therapy is delivered 5 times per day, 1-hour sessions separated by 3.8-hour rest periods, and importantly, the device longevity is more than 20 years. The electrophysiologic action, the device senses the intrinsic QRS initiation, then it delivers 2 biphasic pulses during the absolute refractory period. During this period, as you all know, you cannot trigger new cardiac muscle contraction. There is no propagation of the impulse. This is known as a non-excitatory stimulation, where there is increased influx of calcium ions into the cardiac muscle cells. The lead is implanted, as you see here, in the right ventricular septum, and the cardiac modulation signals are applied, and we register the pressure changes intraventricularly. When there is more than 5% change within 10 minutes after application of the signal, this is considered adequate. If not, then we should change the lead position. Contraindications: patients with mechanical tricuspid valve, patients having reversible cause of heart failure like valvular heart disease, and patients in whom vascular access is not possible. The concept of dual chamber pacing, right ventricular pacing, actually is important because I think it's the basis that they used the modulation therapy afterwards. The BRIGHT study is a famous one that was published at 2007, where the bifocal right ventricular pacing at the apex and outflow tract was used in patients eligible for CRT, having left bundle branch block and ejection fraction less than 35%, and they found that there is improvement of ejection fraction, 6 minutes walking test, and the quality of life. We did also a study, a small study in Asyut University at the time, and we used dual chamber pacemakers where we put 2 ventricular leads in the septum and an atrial lead. And actually this is one of our patients having idiopathic dilated cardiomyopathy. After 3 months and 6 months, we can see the improvement in ejection fraction and reduction of mitral regurg in these patients. So actually this worked for at least 6 months. However, conflicting results were found afterwards, and this large study, multi-center retrospective study in UK, assessed all CRT implants, and they included 2,548 patients where patients failed coronary sinus lead implantation, used bifocal right ventricular pacing. Strangely, only 93 patients of each group were included in what's called propensity matched analysis. They concluded that there is increased all-cause mortality and heart transplant in dual RV pacing versus biventricular group. However, the authors claimed that they had conflict of interest as they received the training grants and research grants from CRT manufacturers. Back to the cardiac contractility modulation therapy and its mechanism of action in reduced ejection fraction. The first mechanism is increased cytosolic calcium, and this effect was proved in a canine heart failure model where phosphorylation of the phospholamine was rescued by cardiac contractility modulation, allowing increased calcium reuptake to sacroplasmic reticulum. But this effect was acute only at the site of implantation of the leads, not the remote site of the lead. The second mechanism is on chronic basis, where cardiac contractility modulation therapy has proved protein expression of phospholamine in the left ventricular myocardium at the interventricular septum, the site of lead implantation, and the left ventricular free wall as well. So this effect was observed at long term after 3 months. In humans, this study was done where endomyocardial biopsy after 3 months of the therapy on and 3 months off and vice versa, and it was found that alpha MHC, which is a gene expression of adult gene type, was found in patients having the device on compared to baseline and the device off. Also, rebalancing of cardiac autonomic tone and reduction in cardiac fibrosis was proven in animal models. So the effects are progressive, leading to reverse remodeling of the left ventricular 3 and 6 months after implantation of the cardiac contractility modulation therapy. In patients with heart failure and preserved ejection fraction, overall the improvement in myocardial relaxation and reduction in the volume of interstitial fibrosis explained the clinical effects in patients with preserved ejection fraction. This is a rabbit model where the therapy exerted a protective effect against myocardial fibrosis, and these are the slides of collagen in the patient group having cardiac contractility modulation therapy and heart failure group without therapy, and the sham group who were actually the best. This study was recently published at 2022, and it included 47 heart failure patients with preserved ejection fraction from 17 centers in Europe and Australia with ejection fraction more than 50%, and we can see the improvement of the life score until they reached 24 weeks of implantation. They also tested the echocardiographic parameters of diastole, and they found that suggesting benefits of cardiac contractility modulation in patients with heart failure with preserved ejection fraction. The safety and efficacy of the device was approved in clinical trials before actually it was FDA approved. These are the 5 main trials. The most important is the fixed heart failure 5C, and the last one. This study is called the pivotal study, at which it was FDA approved afterwards, and they found that it is safe and improves exercise tolerance and quality of life in these patients. What about the long-term clinical experience? This study was recently published in 2021, and it included patients at 3 tertiles of ejection fraction, less than 25%, 26 to 34%, and more than 35%. And they found that the NIHA class, quality of life, and ejection fraction were improved after the therapy. And these effects were maintained after 2 years of implantation, and survival rate improved throughout the 3 years of the study. Septal myocardial scar burden is important, and we should not put the lead at the site of scar. Improvement in NIHA class was reported at follow-up when leads were placed at segments with a scar burden less than 25%. The cardiac contractility modulation therapy in the guidelines. Well, cardiac contractility modulation has been evaluated in patients with NIHA class 3 to 4, ejection fraction of 25 to 45%, and QRS duration of less than 130 milliseconds, and was associated, according to guidelines, with small improvement in exercise tolerance and quality of life. So the evidence is considered insufficient to support specific guideline recommendations for reduction of mortality and hospitalization using these devices. That's why the FDA advised this prospective, multi-center, non-randomized, single-arm, open-label study of 620 subjects receiving the Optimizer SPART device. The study started at January 22, 2020, and will be ended at March 26. And hopefully, after the results of this large study, the device can be included in the guidelines. In conclusion, accruing evidence suggests that cardiac contractility modulation may fill the gap in device-based heart failure therapy across the range of ejection fraction who are not candidates for CRT or are CRT non-responders. However, the mechanism through which cardiac contractility modulation exerts its beneficial effect remains incompletely understood and is an area of future study. Thank you.
Thank you very much. That was a heroic effort to explain to us something which many of the people in the room, including myself, did not understand so far.
Yeah.
And could you tell us in one sentence, where is the place of cardiac contractility modulation today in the treatment of heart failure? One sentence.
It's been used since a large perhaps more than 15 years it was used. However, it's not yet inside the guidelines. We are waiting for this large study I mentioned to put it inside the guidelines. And I hope and I think it will be beneficial for a lot of patients who are actually seeking benefits in their treatment, although they are having the guideline-directed medical therapy complete.
Thank you, Professor Dr. Rai, for this presentation. But I have a question for you, Professor Peter. We are hearing about cardiac contractility modulation long time ago. It seems to be beneficial in patients with narrow QRS, but the evidence is limited, no more progress. Is it failure? Do you consider this? Because it's long time ago.
Thank you very much for your question, but with all my wisdom accumulated during the last 4 decades, I can give you the question to your question, and this is the glass full, half full or half empty? However, having what we have in heart failure, the armamentarium of an excellent drugs, of an excellent devices, and an excellent perspective how we are going to approach this, I think that according to my knowledge and my understanding, this method has very limited value within what we are doing today. That will be my approach. In the recently published ESC textbook on heart failure, we had the chapter on the cardiac contractility modulation. So it's there, but it's not. It will be not the first time that we are surprised with the effect of something which already look hopeless at the beginning. So I think we should leave all doors half open and see what the future will say. Karen, please.
Thank you. I really like your presentation, and I have a little bit different view. I think we cannot distinguish well which therapy works for whom, and if we get better with it, there might be a subgroup of patients who really benefit for it for refractory heart failure. Can I quickly ask you, what's the cost of the of the device?
About what?
What is the cost of a procedure?
Actually, it's very costly, and it's not present in the Middle East at all. And I think all our studies, and not in the general population. However, after some time, I think if it is used and it is proved to be useful for these patients, the cost will decrease, like CRT at the beginning and now. Tim?
Thank you, Professor Dua, for your intelligent lecture. And I have a question for you and for the panel. Can we consider the cardiac contractility modulators, in spite of lacking a good evidence of its beneficial outcome in heart failure patients, can we just consider it a hope for the patients who are CRT not responders or CRT failure? Can we just consider this as a hope, because device therapy is largely applicated in heart failure patients, the patients who have a very limited hope to improve their quality of life and symptoms? Thank you, Dr. Dua. Thank you.
I think Professor answered the question, and he said that the door is half open, and we are looking forward to the results of the studies. Yes. It's a hope, and we always.
I would say not now.
At 2026 is not so far, so we hope at 2026.
Yeah, we will wait for the results for the future research, but I feel it seems that's not beneficial, because I specifically heard a long time about it, so I thought that it's near future there will be positive data, it will be introduced in the guidelines. Now we are hearing on conduction system pacing very, very strongly booming in rapidly versus this. So we will wait, but I'm not, and actually I don't think that it will be helpful for our patients, but let's wait for more evidence.
Yes, I think the same idea. We should wait for the futures studies to clarify the use or to direct it to the guidelines. Until this, we're still waiting for this hope.
Okay, ladies and gentlemen, it's time to close the session. I would like to thank you all the presenters, but also the audience, and please consider this exciting session closed. Thank you very much.